Hello everyone, this is Ahmed Naggar. Today I'm going to talk about one of the most common and critical medical issues we are dealing with every day in our career, acute hyperkalemia. So let's get started.
So first let me tell you a brief information about potassium in our body. More than 90% of body potassium is intracellular. Body is getting rid of potassium by two mechanisms. First, excretion by the kidney, and this is the predominant way. Second mechanism is shifting potassium from extracellular to intracellular by sodium-potassium pump, which is regulated by insulin and catecholamines. Let's see the categorization of potassium levels in the blood. So we can consider it mild elevation from 5.4 to 5.9 and moderate from 6 to 6.4 and severe more than 6.4. Now, let's talk about the causes of hyperkalemia, which are four main causes, and I will give hints about each. First, excessive potassium intake. Second, redistribution. Third, impaired renal potassium excretion. Fourth, pseudohyperkalemia. I will start with excessive potassium intake, which is mainly combined with renal issues like renal failure or diabetic nephropathy. Second reason for excessive potassium intake is the medications that affect the renin-angiotensin-aldosterone system, which is regulating body blood pressure and fluid balance. Examples for this medication are potassium-sparing diuretics, ACE inhibitors, ARBs, and direct renin inhibitors. Last reason for excessive potassium intake is the blood transfusion. And this will be more common if the blood stored more than 12 days. This is due to lack of produced ATP, which is the reason for leakage of potassium to extracellular. As a result, potassium would be very high, up to 60 millimole per liter. However, this is less common now because of the potassium filter and better storage conditions. Second main cause of hyperkalemia is the redistribution, which can be caused by DKA and HHS, and we will talk about DKA and HHS with more details later. Second reason for redistribution of potassium is rhabdomyolysis, and rhabdomyolysis can be happen secondary to skeletal muscle injury. So leakage of muscle cell content such as myoglobin and potassium gonna happen. Third reason for redistribution of potassium is metabolic acidosis. As we know, acidemia tends to shift potassium from intracellular to extracellular. Then we will come to the fourth reason, which is digoxin toxicity. Since digoxin inhibits sodium-potassium pump, as a result, the intracellular sodium will be increased and extracellular potassium will be increased as well. Last reason for potassium redistribution is beta blockers. In view of the fact that beta blockers are not allowing the cell to reuptake potassium. Third main cause of hyperkalemia is the impairment of renal potassium excretion, which can be secondary to renal failure, hyperaldosteronism, or some medication that affects potassium excretion, like ACE inhibitors or ARBs or NSAID. Fourth main cause of hyperkalemia, which is not a real cause, it is just a reason for misleading us, artifactual increase in serum potassium due to its release from cells during or after venipuncture. That can be happened when the tourniquet is too tight or left on too long or the blood is left sitting too long. All those can cause hemodialysis. Now let's talk about signs and symptoms of acute hyperkalemia. Acute hyperkalemia can be presented by severe muscle weakness or paralysis, cardiac manifestation like ECG changes, arrhythmias, or cardiac arrest. It can be presented as well with reduced urine acid excretion. The ECG changes are depending on the grade of hyperkalemia. It can start with peaked T wave, but with some more severe hyperkalemia, we can see wide PR interval, wide QRS duration, in addition to peaked T wave. In some cases with very severe hyperkalemia, we can see loss of P wave with bizarre QRS complex like this ECG. Many features of hyperkalemia can be seen here: prolonged PR interval, peaked T wave, and broad bizarre QRS complex. Let's talk about the management of hyperkalemia. So we can manage hyperkalemia according to how severe it is. So with mild hyperkalemia, it is enough to stop or halt potassium containing or retaining drugs. Additionally, low potassium diet can help. Then moderate hyperkalemia with no ECG changes can be treated by promoting urinary potassium loss with appropriate use of fluids or loop diuretics, and this should be only if the patient is suffering fluid overload. Second thing is removing excessive potassium with peroral sodium zirconium cyclosilicate, which can be given as 10 grams 3 times per day for a maximum of 3 days. Keep in mind that you need to recheck urea and electrolytes after 1 to 4 hours from starting the medication. Then recheck urea and electrolytes daily. Sodium zirconium cyclosilicate increases fecal potassium excretion. Normokalemia can be achieved typically within 24 to 48 hours. Consider stopping sodium zirconium cyclosilicate when potassium is less than 6 millimole per liter, or stop it immediately when potassium is less than 5.5 millimole per liter. There are some precautions need to be considered while dealing with moderate hyperkalemia. First, exclude pseudohyperkalemia by repeating the blood sample with more proper way. Second thing, ensure adequate hydration. Monitor urine output. Third thing, treat hypotension. Last thing, monitor renal function. Now we will talk about the management of the most critical presentation of the hyperkalemia: moderate with ECG changes or severe with ECG changes. And the management will be the same for both. First, we need to protect the heart by giving 10 ml of 10% calcium gluconate, which will be given over 5 to 10 minutes, and it can be repeated up to 3 times only. Second thing, we need to help rapid shifting of potassium from extracellular to intracellular. That can be done by 2 ways. First, by giving 10 units of insulin, act rapid, and 50 ml of 50% glucose, or by giving 8 units of insulin, act rapid, and 100 ml of 20% glucose. This should be given over 15 to 30 minutes. Third thing is 10 mg of nebulized salbutamol. Then we can prescribe oral sodium zirconium cyclosilicate. IV sodium bicarbonate can be given as well, depending on the serum pH and the severity of the symptoms. Finally, if the patient is overloaded, we can give loop diuretics. So, what are the precautions need to be taken during treating moderate and severe hyperkalemia with ECG changes? First, we need to repeat urea and electrolytes after 1 hour, then after 2 hours, then after 4 hours, then after 6 hours, then after 24 hours, and this would happen in high dependency units. Second thing, we need to check the capillary blood glucose 15 to 30 minutes after the initiation and within 1 hour from completion of the act rapid infusion to treat hypoglycemia if present. Keep in mind checking capillary blood glucose closely for 24 hours. Eventually, we need to repeat ECG to make sure that the changes are corrected.
At the end, if all the mentioned therapies didn't work, we need to start hemofiltration for the patient. I hope you enjoyed this topic today. Thank you.